Hello, everybody. Thank you for participating in this virtual rural trauma development course. We're going to talk about disability. Essentially, what we're looking at is brain and spinal cord and how we can prevent any secondary brain injury. So to continue the scenario that has already been presented, this patient has been intubated, chest tube has been placed, IV fluids have been started. Bleeding has been controlled, resuscitation is continuing. The rapid sequence intubation medications have worn off, and the patient opens his eyes to voice and withdraws to painful stimulus. The question becomes, what is your role in the management of this his neurologic condition? So the biggest thing that we're worrying about at this point in time, hopefully by now, this patient has already been, the trauma team has already been notified. If this patient is in my emergency department, as soon as we recognize that this is going to be beyond our capabilities, we are already going to be making the arrangements for transportation and transfer. And also in consultation with the trauma team, we can also determine the best way to manage any neurological complications that may arise. So our objectives are basically identify possible head and spine injuries. Obviously, if you have a suspicion that there is a potential spine injury, to notify the trauma team, perform a mini neurological exam if possible, hopefully calculate the GCS, prevent secondary neurologic injury, and that's going to be very, very key in our objective, and then determine the need for early transfer. And hopefully this has already been done. You may have a situation or a scenario where you have a patient that's relatively stable, and you go through your primary survey and you really haven't identified any major life-threatening problems. Also keep in mind that these things can change, so it's very important to always go back and reassess anytime that there's a change. And you might find things on your secondary survey, or you might find a potential problem in the head and C-spine that will need transportation or transfer to a trauma center. Facility preparation, this is very important. It's actually very helpful. Old school, you'd have to remember all the doses and drugs and procedures and coma scales, and having these available on the walls of your trauma bays is very important and also very helpful. Those of everybody that have been involved in traumas, it can be a very trying time. It's very stressful, so the less you have to actually memorize, the better it's going to be. So having drug dosages for rapid sequence intubation associated with patient weights, the appropriate mobilization equipments, having a GCS chart in your trauma bay. These are all things that will help facilitate the better care of the trauma patient, actually. Okay. As part of the primary survey, we're going to do a mini neurological exam. Obviously, all trauma patients have a cervical spine injury until proven otherwise. And in a rural trauma setting, they're actually going to be presumed to have a cervical spine injury even after they have had a CT scan at our facility. We're still going to assume that there is some secondary injury, and we're going to maintain that spinal mobilization. Level of consciousness, it can be as simple as, hey, how are you? What's your name? Where are you at? What happened? Obviously, people signs, any lateralizing signs such as decorticate or decerebrate posturing, in the Glasgow Coma Scale, which will be important in determining whether you need the need for definitive intervention. Obviously, if the patient is awake and alert and they can talk to you, you want to evaluate the possibility of a spinal cord injury by having them demonstrate motor and function and sensory on both sides. And then if they do have an area of deficit, where is it? And then that's something that you need to document and make sure that the receiving hospital is aware of what's going on. Okay. If possible, do a mini neurological exam. And it might be just as simple as, hey, how are you? What's your name? Okay. Do not delay intubation to do this. But if you're able to do it quickly, then it will be helpful for the receiving team that they were awake before the intubation, or they were obtended, or they were completely unresponsive. This is information that the receiving hospitals are going to want to know. And the Coma Scale is actually a very good tool. As Dr. Dumeyer famously says, a rock has a GCS of 3. So an inanimate object can have a GCS of 3. Kind of funny to look at it that way, but it actually rings true. On your screen, you have eye-opening, motor response, and verbal response. I've always remembered it as EVM 4, 5, and 6. That makes it easier for me to remember. But having a chart on the wall will definitely make things easier to remember. Anybody less than 8 on the Glasgow Coma Scale has the need for a definitive airway. So the old adage, GCS less than 8, intubate. Doesn't matter what the respiratory status is. They may have good respiratory status, they might have good oxygenation, but if their GCS is 8 or less, they need to have their airway secured. That's a very important point and something to remember. Some examples of bleeds that you might see. These are things that you might see as you go through your resuscitation. You might notice that initially the patients are stable, so you do a workup and you find these on CT scans. You have epidural hematomas, which basically is more arterial bleeding. These are the patients that basically have a brief loss of consciousness, probably a period of lucidness, and then they rapidly decompensate. This does not cross the sutural line, so usually you see it in kind of it's fairly localized, almost in an oval shape or a teardrop shape. Subdural hematomas or more venous bleeds. They can be slower, over hours to even days. You might get a delayed presentation where you have a patient comes in 2 days after they fell down and struck their head. The subdural hematoma does cross suture lines, so oftentimes you will see kind of a half moon shaped or a crescent shaped deformity or shadowing there in the CAT scan there. And then lastly, you have the parenchymal bleeds as well. Okay. So recognition of a patient with a brain injury, sometimes it can be difficult. As Dr. Morrissey pointed out, sometimes these patients might have underlying dementia. They may have underlying medications. They may have underlying alcohol intoxication. All these things can certainly mimic a brain injury. Patients that are hypotensive can also mimic a brain injury as well from a mental status change. So clinical signs definitely can give you an idea, but also keep in mind the potential caveats about alcohol and other masking problems. Also, this patient determined the need for transfer. Minor head injuries, it comes down to what your facility's capability is. It comes down to mechanism of injury. It comes down to age of the patient, comorbidities. You might have a 78-year-old person that is not very mobile and they fell down, struck their head. You did a head CT, it was negative. They're on Coumadin, warfarin, Eliquis. They might warrant an observation to make sure that they don't deteriorate. And this comes down to what is the capabilities of your facility. If you have an attending that is willing to watch these patients in case they do deteriorate, then you have to have a plan that you can transfer these patients if it's necessary. If you don't have these capabilities, or if you have an attending that does not feel comfortable, they may need to be transferred to the trauma center just to be monitored. Luckily, the majority of the head injuries that we see are usually minor. 70% are usually within the 13 to 15 GCS, and really you don't need to do any major interventions with them other than make sure that your resuscitations are adequate. Okay. Cervical spine injuries, mechanism of injury is critical. any type of injury above the clavicles, if they fell down, struck the floorboards with their forehead, any back or neck pain. Obviously, if they have altered level of consciousness, they can't tell you what happened. Those are things that you should always assume a cervical spine injury is present until proven otherwise. And distracting pain is also a very important caveat as well. If you have someone that's got a femur fracture or a pelvic fracture or a bony fracture, it is very, very painful. So it might be so painful that they may not notice or they may not recognize or may not clue in that, yeah, they have a cervical spine fracture or a thoracic or a lumbar spine fracture just because of the femur fracture. So that distracting pain should clue you into, okay, they have a spine injury until proven otherwise. And here's some examples that you see. On your left-hand side, you have C5 and C6 jumped facet fracture. In the middle, you have an L1 fracture, which looks to be displaced. And then the right-hand side of your screen, you have a C2 hangman's fracture. And in about a quarter of all patients with spinal injuries have at least a mild traumatic brain injury associated with it. And here is the major distribution, mainly because of the surrounding structure. Cervical, obviously, is the most common, just because there's not a whole lot of structural support around the cervical vertebrae. And an axial spine injury at one level, you should suspect a potential spine injury at other levels as well. So for the injuries, the most important thing is that they're awake. Document the level of sensory and function. Anytime that you do any type of intervention, go back and reassess, and any changes, make sure you assess that and notify the receiving trauma team. Steroids are not recommended for spinal cord injuries. And then transportation, padded full spine immobilization, usually with a long spine board and with warm blankets. Keep in mind the spine boards are mainly for transportation only. You do not want to keep patients on spine boards for long periods of time for reasons of skin breakdown and other problems. So, secondary neurologic injury, the most common reason is because of poor oxygenation, inadequate perfusion. To touch on one of the points that Dr. Morrissey made, you may have patients that have underlying hypertension. They may run normally 140s, 150s, 160s, and so their brain is very sensitive to those changes and those pressures. And so a blood pressure of 90 may not be adequate enough to really perfuse that brain. If they have a primary brain injury, obviously in addition to other injuries, it's going to be very important to maintain that oxygenation to the brain to try to preserve as much brain function as you can. And so always address the hypotension and oxygenation are the two things that you can really readily identify and address to really help prevent secondary neurological injuries. Frequently reassessing the ABCs if there's a problem. If you notice a change, go back and repeat your ABCs in your primary survey and then do the corrective actions as you need it. As Dr. Morrissey said, hypotensive resuscitation is contraindicated in severe head injuries. The exact number is, I'm not sure that exact number. Ideally you want around 100 to 110 at least from a blood pressure standpoint, also having oxygen on these patients, and then adequate resuscitation to kind of help prevent possibility of secondary anoxic brain injury. Okay. Some pitfalls that you see is failure to record the serial GCS scores, clearance of the cervical spine, x-rays alone. Realistically, I mean, if that's all the capability you have is the lateral x-rays, fine, but you cannot clear a cervical spine based upon x-rays by themselves, and nor should you. I do know that with our facility, when we have a patient that is a trauma patient and we scan the head and the C-spine, if they're both negative, we still leave the cervical collar in place until they get to the receiving facility. Missed cord injuries in the presence of negative x-rays, especially with younger adults and children. You might not have radiographic evidence of an injury, but they still might have some spinal cord injury. So that's very important to note. So just because you don't see a fracture does not mean they don't have a cervical spine injury. Inappropriate use of backboard. Here again, the backboard should be utilized as a transport median only. And then failure to keep the spine aligned during the movement of the patients. So those are the major pitfalls that you see. So basically, in summary, the most important aspect of disability is making sure that you have adequate resuscitation for these patients and adequate oxygenation to kind of help prevent the secondary brain injuries.
Okay, if you have any questions, don't forget to put them into the chat box. We'll get to them. But in case you don't, Dr. Baker has some for you.
Okay. So the first question we have is a 32-year-old woman has a GCS of 8 after a fall down a flight of stairs. Her blood pressure is 85/60, heart rate is 120. Her treatment must include A, hypotonic fluid resuscitation, B, mannitol, C, hyperventilation, D, endotracheal intubation.
Okay, Mike. Okay.
So it sounds like the majority of you have chosen D, which is correct, endotracheal intubation. The primary reason for this is she has a GCS of 8, and from the mantra of rural trauma, a GCS of 8, she's unable to maintain her own airway, or she's in danger of losing her airway, so you want to make sure you place the definitive airway, which would be endotracheal intubation. Okay, secondary brain injury. A, refers to damage that occurs shortly after the injury. B, does not influence overall outcome. C, can be minimized by maintaining oxygenation and blood pressure. D is the same as spinal shock. I think the general consensus is C. Here again, it goes to adequate resuscitation and oxygenation. Usually a primary brain injury, a secondary brain injury is usually the result of hypoxemia and hypotension as well. Close that out. Okay.
We're going to have you just go on to environmental. Just click
okay. All right. So kind of reiterating the key points, prepare the team in the facility, ideally having those charts for the GCS, vital signs, dermatomes, rapid sequence intubation medications are all good things to have in your facility, readily available. Identify head and spine injuries, calculate initial and serial Glasgow Coma Scales, prevent secondary neurologic injury, and maintaining spinal alignments.
Okay, let's go ahead and keep
we're going to go right straight into exposure. The patient's temperature is 94 degrees. The team notices that his clothes are wet. So the question becomes, what is your role in the management of hypothermia? Okay. The objectives for this is to determine why the injured patient should be exposed during the initial assessment and resuscitation, environmental control and what that means, and then the teamwork required to expose and take care of the environment. Keep in mind that all trauma patients are presumed to be hypothermic. It does not matter the time of the year. You may have someone that is injured while swimming and they're wet, and they could become hypothermic just because of the wind. So things that may give you a clue is the exposure, how long were they there, what was the surrounding temperature, is it windy, is it rainy, is it cold, are they bleeding? Our attempts, such as cold IV fluids and cold blood, can also contribute to hypothermia, which contributes to that lethal triad that Dr. Morrissey and Dr. Dumar have stated. Drugs and alcohol, they can impair the body's ability to maintain euthermia. So these can be factors that can contribute to patients being hypothermic. And again, the lethal triad, we can prevent the hypothermia by adequately getting the clothes off, exposing them, and then covering them with warm blankets. You can do things such as the bear huggers, and obviously warm IV fluids and warm blood. So hopefully you have some sort of a method to be able to do such. Keep fluids in a warmer. You may have a blood warming device, which will help in giving fluids as well as blood. Okay. So the important part of the primary survey is you want to warm the room as much as possible if you have those means. If you don't have the means to warm the room, then you want to do everything else you can do. So that would include removal of clothes, not only to help prevent further hypothermia, but to expose any potential injuries that you might miss. What you don't want to do is have a patient that you transfer to the trauma team that you didn't fully undress, and you miss the bullet hole out of their left butt cheek or something like that. Kind of embarrassing when that happens. So you want to be able to find all presenting injuries. Maintain their core temperature, and also warm the patient with things such as blankets, warm IV fluids, and bear huggers. Okay. Temperature assessments. Obviously, I think rectal temperature is probably the best. I don't recommend the skin oral temperatures or even axillary. A lot of people do axillary temperatures, and those are variously unreliable under normal circumstances. But a hypothermic patient, trauma patients can be very unreliable. Skin color is definitely not reliable, especially due to it could be underlying maybe medical conditions. They may have things like Raynaud's, which might impair that skin color. So those things are not very reliable in the assessment of the temperature. And examples of warming equipments would be blanket and fluid warmers, warming devices, and a rapid infuser. Other considerations, if you have someone that potentially has been exposed to a hazardous material, you want to make sure you decontaminate them prior to the facility. If the decontamination requires them to be hosed down, keep in mind that's going to further cause them to become hypothermic. So make sure you have everything ready to go when they arrive in the bay. All contaminated clothing should be removed. If possible, get a hazardous material exposure history, and then know what your protocols are for any decontamination instructions. Okay. Biggest pitfalls here is not removing the clothes, administering cold fluids. Those are two things that really can really be avoided and should be avoided. Another one would be failing to take a temperature while you're doing your surveys. When you roll the patient to check the back, do a rectal temperature. If you suspect they have a spinal injury, you might want to do a rectal exam to check for rectal tone. It's a perfect time to do a rectal temperature at that point in time. Okay, and also, failure to recognize that with someone that is hypothermic, their oxygenation may not be very good, or it might be very good, and they're reading poor because they don't have good blood flow to their extremities. So the main take-home point with this is undress the patients, expose them, remove wet clothing, and then warm them up with blankets and bear huggers and warm fluids and warm blood. So we're going to go on to the questions. You're assessing a 24-year-old woman in your community hospital emergency department. She was thrown from her snowmobile. Your team suspects a closed head injury, pelvic trauma, and a fractured femur. All the following statements regarding her resuscitation are true except A, the patient's wet clothing should be removed. B, the receiving area should be warmed to 80 degrees Fahrenheit prior to her arrival. C, packed red cells should be placed in a microwave oven briefly before administration. D, passive rewarning, dry blankets, milder sheets, plastic wraps should be used. So go ahead. Okay, I think pretty much a consensus. C is the correct answer. You don't want to put your red blood cells in a microwave oven. So that's where you'll get into a lot of problems if you do that. So, all right, that's the end of the exposure and disability part. I think we have a video for. Is there one more question? Okay. Sorry. So I only had two. Or we can do the video. Okay. We have a third question. It is a warm summer afternoon. 58-year-old male pedestrian was struck by a motor vehicle an hour ago and is now being assessed in your rural hospital emergency department. He is tachycardic with a blood pressure of 90/60, restless, somewhat uncooperative, and being resuscitated with crystalloids. Which of the following statements is correct? A, hypothermia is not a significant concern in this patient. B, oxygen saturation measurements will be highly reliable in this individual. C, room temperature should be optimized for trauma team members' efficiency and comfort. D, oral temperature measurements in this patient may not be reliable. Okay, I think the consensus is D, oral temperatures are not reliable, and that is the correct answer. Keep in mind, hypothermia could be a problem in a trauma patient, especially in the summertime, depending on the situation. Someone that is hypothermic, your O2 sats will not be reliable or may not be reliable. And then you want to warm the trauma bays if you have the capabilities. Now, some places do not have those capabilities, and that's why you need to make sure you have other means at your disposal, such as blanket warmers and the bear huggers. So. Okay. Okay, I'll let you go do that. Thank you, everybody.
We just got a report from EMS over the radio. 25-year-old female, hunting accident, fell approximately 15 feet from a tree stand. They've been in the woods with her, trying to get her out for at least 30 minutes. ETA 3 to 4 minutes.
That's a significant fall from a tree and a lot of exposure. So actually, why don't you go ahead and activate the trauma team? This may actually qualify. Okay, so patient's on the way in. Kim, when she gets here, if you'll put the monitors on for us, oxygen, pulse ox, and the cardiac monitor, and see if she has IV access. Jody, when she gets here, obviously, Jody, we're going to end up cutting her clothes off and see what we have. All right. Patients here.
Well, doctor, we have a suspected spinal cord injury, also hypothermic, stable vital signs.
Okay, what's your name? Enter. Can you hear me okay? All right, you're breathing okay?
Yes.
Any chest pain?
No.
All right, so she's been, vital signs have been stable
Yes.
hemodynamically?
Yes.
So go ahead and give us a full report.
Basically, he's 25, fell out of a tree stand about 15 to 20 feet, prolonged extrication time due to her location, cold outside, it's about 25 degrees, unknown length of time, how long she was there before we got there.
Okay.
She has oxygen, we have her on C-spine precautions, we do have an IV site in her left arm. And she's been stable the entire time.
Okay.
She's complaining of pain to her mid to lower back. She cannot move her legs.
All righty. So we're going to go ahead and move you over here. Just bear with us. We're not going to have you. Get her detached from the cart and take her over with the board.
Okay, I'm done. Okay, so
Are we good to go?
there.
Okay, on my call. On 3. 1, 2, 3. All righty.
Doc, you want to hang around for this?
Yeah, if you would just for some extra hands, and also we may need a transport as well once we figure out what's going on. So, take some deep breaths for me. She's got good breath sounds on the right and the left. Heart rate's okay. So airway's patent, bilateral breath sounds, and she's not significantly tachycardic. Jody, thank you for getting our clothes cut off, and if you can get us some more blankets to put over top of her. We're going to go ahead and roll her off, log roll her off of this longboard, but first off, can you have any problems with pain right now?
Both in my back,
Okay, in their upper back or lower back?
lower back.
Okay, can you wiggle your fingers for me? Both sides? You feel me touching you?
Yes.
You feel me touching you over here?
Yes.
Wiggle your toes for me. Okay, wiggle the other again. You feel me touching you?
No.
Okay, so we may have a spinal cord injury here, so we need to log roll her. If you can stabilize her C-spine for us, we'll take the blocks off. You'll get the legs. I'm going to roll her over. We have some warm blankets. I'm going to pad the back for her. When we roll her, the clothes have been cut. We're not taking her clothes off in the video, but this is where we would actually roll the clothes underneath and take them out once we get her up on her side. So you've got the head. Go ahead and give yourself a big hug there. And the IV's clear. Oxygen, everything's good.
We're going to roll away from you. We're going to do it at the count of 3. 1, 2, 3.
Okay. Anywhere I'm touching and hurt on the back here. Any pain?
There.
Right in here, mid-thoracic, down here?
Yes.
Okay. And I would do a rectal exam here. She has no rectal tone. I'm going to take the backboard out. Slide it out off of this. And we're going to put some warm padded blankets down for her comfort. Go ahead and roll her back now.
Right, count of 3. 1, 2, 3.